Look at this generated video of a braided steel cable fraying and snapping under massive tension. It is a purely structural failure. In sports medicine, practitioners routinely fail to cure chronic tendon pain because they are treating a disease the patient does not actually have. For decades, the default diagnosis for chronic tendon pain has been tendinitis. In medical terminology, the suffix itis explicitly dictates an active chemical inflammatory process driven by immune cells, but histological assessments reveal a different reality. The correct terminology is tendinopathy. This describes a well-advanced failure of a chronic healing response, where the tissue simply breaks down. This pathology occurs in major tendons, like the Achilles, the patellar, and the rotator cuff. Surprisingly, it appears in both chronically overloaded tissues and in completely unloaded states, leading to a loss of mechanical integrity. Therefore, applying chemical anti-inflammatory treatments like ibuprofen or cortisone to a structural, non-inflammatory disease guarantees clinical failure. Microscopically, the left side shows healthy tendons with parallel, organized collagen designed for extreme loads. The right shows tendinopathy, a tangled matrix and disorganized tenocytes. Inflammatory immune cells are totally absent. Instead, abnormal neovascularization and nerve fibers invade the matrix, causing chronic pain. Because the disease is defined by a disorganized physical matrix rather than chemical inflammation, the intervention must be a mechanical remodeling of the tissue. The universally recommended first-line treatment for tendinopathy, for both athletic and sedentary patients, is a 12-week eccentric exercise program. A common misconception is that eccentric loading builds muscular strength. In reality, its purpose is to force structural adaptation within the tendinopathic tissue itself. This demonstrates mechanotransduction, where physical tension prompts cellular signals for structural remodeling. As the muscle lengthens under a heavy load, it directs mechanical stress along the line of pull, forcing disorganized collagen fibers to physically align and form healthy new cross-linkages. Furthermore, color Doppler sonography has proven that this specific eccentric training directly decreases the pathological neovascularization in the affected area. Eccentric loading is highly effective because it uses direct mechanical force to reverse the structural haphazardness of the pathology. The primary alternative or adjunct to eccentric loading is repetitive low-energy extracorporeal shockwave therapy, or ESWT. ESWT is a non-invasive treatment that delivers acoustic shockwaves to injured soft tissue to reduce pain and promote healing. Looking at this tissue cross-section, we see the physics of ESWT. Incoming sound waves generate mechanical forces directly inside the failed tissue, instantly creating microscopic cavitation bubbles. Their rapid collapse creates microimpacts that stimulate healing and inhibit pain receptors. Randomized controlled trials, or RCTs, which are studies that randomly assign participants to eliminate bias, prove that low-energy ESWT and eccentric training produce comparable outcomes, both vastly superior to a wait-and-see approach. The clinical data reveals a powerful synergy. Combining eccentric loading with low-energy shockwave therapy yields statistically higher success rates than either therapy alone. Whether the physical force comes from internal muscle loading or external sound waves, applying controlled mechanical stress is the definitive trigger for tendon repair. For tendinopathy that proves refractory to eccentric loading and ESWT, clinicians turn to high-volume injections as a rapid, inexpensive fallback. The injection cocktail consists of a large volume of normal saline, anesthetics, and hydrocortisone acetate. While hydrocortisone is a steroid, its inclusion prevents acute mechanical swelling caused by the massive fluid volume. It is not meant to biologically heal the tendon. Under ultrasound guidance, the needle strictly bypasses the Achilles tendon body, injecting fluid directly into the Kager fat pad triangle. As the fluid rapidly expands, the massive influx creates local mechanical pressure that physically stretches the surrounding tissue. This physical stretching forces the pathological neovessels and their accompanying nerve supplies to stretch, snap, or occlude, instantly cutting off the pain signal to the brain. High-volume injections are highly effective precisely because they are a mechanical disruption of the blood and nerve supply disguised in a syringe. Despite this evidence, a common clinical mistake is the continued reliance on orthobiologics and chemical injections designed to target inflammation or speed up biological healing. Take platelet-rich plasma, or PRP. PRP is a concentration of a patient's own platelets used to accelerate the healing of injured tendons. While the theoretical rationale involves flooding the area with growth factors, the actual clinical evidence is lacking. A definitive double-blind, placebo-controlled trial demonstrated that PRP injections resulted in no greater pain relief or activity improvement than a simple saline placebo injection. Autologous blood injections, where a patient's whole blood is re-injected into the tendon, suffer from a lack of robust experimental models. Any clinical success is strictly anecdotal. Similarly, the use of intratendinous corticosteroids is heavily discouraged. Meta-analyses show little benefit, and injecting directly into the tendon carries a severe risk of tissue rupture. Relying on unproven chemical biologics ignores the physical, structural reality of tendinopathy and wastes critical patient rehabilitation time. Tendinopathy is a continuum of mechanical tissue failure, and therefore it requires a mechanical clinical response. Looking at this flowchart, we can define a strict algorithm. The first step is a mandatory 12-week eccentric loading program. For improved success rates or slight clinical resistance, the second step is to combine eccentric loading with shockwave therapy. When structural loading totally fails, the third step is to deploy a high-volume extratendinous injection to physically sever the pain mechanism. Surgical management must be strictly reserved for patients who have exhausted this entire conservative mechanical hierarchy. To cure chronic tendon pain, clinicians must abandon the tendinitis fallacy, stop injecting unproven chemicals, and commit to re-engineering the physical structure of the tissue.